Welcome to Introduction to ICD-10-CM Part 4. I'm Mrs. J, one of the curriculum developers here at AMCI and one of your ICD-10 instructors. Now let's begin. Previously, we discussed in Part 3 ICD-10-CM categories. And we learned AMCI's technique to identify these categories on site. Yes, that was fun. And hopefully, we brought you one step closer to ICD-10-CM coding mastery. And the goals for today are we are going to discuss Section 4 guidelines, ICD-10-CM Section 4 guidelines. We're going to learn about sequencing that first listed code, and we're also going to learn how to identify the first listed code. And finally, we are going to learn how to identify codable diagnoses in documentation. So all codable diagnoses in documentation.
And before we go any further, let's go ahead and read the copyright. CPT is a registered trademark of the AMA. Keyword concept, FTR, CHUN, AMCI Fab 7, AMCI Flip Tap, and MCG are all registered trademarks of AMCI. The credentials CPC, CRC, COC, CPMA, CPB, CPPM, CPCO are owned by AAPC, and the credentials CCA, CCS, CCS-P, RHIA, RHIT are owned by AHIMA, and AMCI does not own the rights to these credentials.
Now let's begin our discussion on Section 4 Guidelines, Diagnostic Coding and Reporting Guidelines for Outpatient Services. Let's do it. All right, coders. Section 4 guidelines are the guidelines for diagnostic coding and reporting guidelines for outpatient services. This is key, coders. You know what this means? This means that these Section 4 guidelines are not for use for inpatient encounters. So again, these are outpatient guidelines, and here is where you're told or directed to use a different type of guidelines for inpatient encounters. Just so you know, for inpatient encounters, we use the Uniform Hospital Discharge Data Set guidelines, and those guidelines are in sections 2 and 3. All right, so let's quickly review the Section 4 guidelines. Number 1, or A, Section 4A, these are the guidelines for selection of the first listed condition. And under that category, you've got outpatient surgery, observation stay, then we go to B. And the guidelines at the B level tell us to use codes from A00 through Z99. We have C guidelines that discuss accurate reporting of your ICD-10-CM diagnosis codes. D, codes that describe signs and symptoms. E, encounters for circumstances other than a disease or injury. F, level of detail in coding. And underneath F, you've got your ICD-10-CM codes with 3, 4, 5, 6, or 7 characters. 2, it instructs you to use the full number of characters required for a code. G, ICD-10-CM codes for diagnosis, condition, problem, or other reason for the encounter or visit. H, uncertain diagnoses and what to do. I, chronic diseases. J, coding all documented conditions that exist. K, patients receiving diagnostic services only. L, patients receiving therapeutic services only. M, patients receiving preoperative evaluations only. N, ambulatory surgery. O, routine outpatient prenatal visits. P, encounters for general medical examinations with abnormal findings. And Q, encounters for routine health screenings. All right, coders, it is time. We're going to review all of these Section 4 guidelines line by line, and I'm going to give you a brief overview of each of the guidelines. We are almost ready to begin. If you have your MCG manual, that is perfect because you probably should follow along in your MCG manual. If you don't have it, you may want to pause the presentation. Now, locate your Section 4 guidelines in your MCG manual, and we'll begin with answering the question, what are these Section 4 guidelines used for? Well, these guidelines are used for hospital-based outpatient services. So services that are not inpatient. What is an outpatient service? Like the ED facility, outpatient clinic. Again, anything that's not inpatient facility. Also, these guidelines are used for provider-based office visits. What is that? Those are doctor visits. So outpatient-based hospital and doctor visits. And remember, do not use these guidelines for inpatient facility coding. Now, if you have the MCG manual, you may want to write in inpatient facility coding because you do use it for outpatient facility. All right, next, our next topic is first listed code definition and use. Well, we use it in the outpatient setting. The term first listed diagnosis is used in lieu of the principal diagnosis. Yes, so whenever you hear people say principal diagnosis very often, and people use first listed diagnosis and principal diagnosis interchangeably. That's incorrect because principal diagnosis is for inpatient facility encounters. So you should only say principal when you're talking about inpatient. Anything else? First listed. And first listed code is going to be the chief reason for the encounter. So this is the chief reason the patient is being seen, and we call it the RFE, reason for encounter. And also, specific coding guidelines take precedence over these Section 4 guidelines. Specific coding guidelines can be found in Section 1C. Yes, there's Section 1C guidelines. We did not review them yet, but those are specific coding guidelines. Next, uncertain diagnosis. And anytime you have a doctor renders an uncertain diagnosis like the patient probably has diabetes. Suspected, the patient is suspected to have osteoarthritis. Or rule out, we're going to rule out an acute myocardial infarction. Well, you know what, coders? In outpatient coding, we don't code that kind of stuff. We code what the doctor actually does, okay? So do not code inconclusive or uncertain diagnosis. Code the most certain. We code to the highest level of doctor certainty. So if the doctor is only certain about a sign or a symptom, let's say the doctor says, oh, we're going to bring the patient in to the ED and we're going to rule out a heart attack. No, we're not. We're not going to code for that rule out. We're going to code for the reason for that encounter, the chief reason for the encounter, which may just be chest pain. Next, selection of the first listed condition. All right, coders. Now, they tell you, we've already learned that you always look up the code in the alphabetic index first and then verify the codes in the tabular list. We know that. But when you have outpatient surgery, you're going to always code the chief reason for the surgery as first listed. Okay? If the patient's in observation stay, there could be two circumstances that they're there. Number one, they could be there for a medical reason, or number two, they could be in observation due to maybe a problem that occurred in outpatient as a result of outpatient surgery. Well, if the patient has been admitted from observation for a medical condition, then the medical condition will be your first listed code. Next, if the patient was admitted to observation from outpatient surgery for a complication, then the reason for the surgery will be your first listed code. And I guess I should have said this. First listed means that the code that you're going to sequence first, the code that you're going to assign first, is also first listed. I think you knew that, but I need to say it too. Next, we have some more topics. All right, so codes from A00 to Z99, guideline B, tells us that we have to use the complete set of the diagnosis coding. Guideline C, accurate reporting of ICD-10-CM diagnosis codes. It tells us that we have to code accurately. We have to follow the documentation. We have to use the terminology that's specified in the documentation, as well as the symptoms, the problems, or the reason for the encounter. We have to consider all of that and make a proper code selection. All right, Section 4, Guideline D, codes that describe symptoms and signs. We know that we code them in the absence of a confirmed diagnosis. We know that. Level of detail in coding. Well, it tells us that we have to use the full extent of the coding characters that are required. To the left of the code, if it's specified in telling us that we need 5 characters, that is what we code. We're going to code the full level of detail in coding. We're going to code to the highest level of specificity. That is where we find that guideline. You're going to hear people saying it all the time. Code to the highest level of specificity. It's guideline F, section 4. Guideline G, ICD-10-CM code for the diagnosis, condition, problem, or other reason for the encounter or visit. We will sequence the chief reason for the encounter first, followed by any additional coexisting conditions and diagnoses. Uncertain diagnosis. This is guideline H. Doesn't that look familiar? Yes. And I know I put it in the section 4 twice, but it's that important. Do not code diagnoses documented as probable, suspected, questionable, rule out. If it's not definitive, then you will not code it. The doctor has to be certain. Code to the highest level of doctor certainty. Guideline H, chronic conditions. We can report them as many times as the patient receives treatment for them. Now, we're not going to code them multiple times, but at any encounter, if the patient is being treated for them, then you code it. And also, you're going to code all documented conditions that coexist at the time of the encounter. Guideline H, you're going to code them all if they by being present and or if they affect the patient's treatment. You're going to code those coexisting diagnoses, and we will show you some examples of many of these guidelines. Also, do not code resolved conditions. Don't code them. They don't exist, so do not code them. However, if they are pertinent to your encounter, you can use history codes to denote or to identify that the patient had a past history. And you only use those history codes if their history of having a disease or illness is pertinent to the encounter that we're talking about. All right, now we're at guideline K, patients receiving diagnostic services. What is a diagnostic service? Well, diagnostic service means that we're trying to diagnose a patient's condition. Don't quite know what it is, but we are trying to diagnose the patient's conditions. Let's say that a patient has an arthroscopy. Let's say they have knee pain and an arthroscopy or arthroscopy is taking place. They they just have knee pain. We're trying to see if there's another condition. All right, so this is what you do. You're going to sequence the chief reason for the encounter first, and then you're going to code also all coexisting diagnoses at the time of the encounter. Now, let's say you have a routine labs took place. Let's say a patient has a pap smear and there's no diagnosis, right? Often a patient can have a lab or a pap smear or something like that, and there's no diagnosis warranting it. So you're going to have to use code Z01.89 for routine labs or radiology. And that might be a bad example because I think there might be a pap smear code. But if there's no code for it and it's a routine lab without a diagnosis, then you're going to code it Z01.89. Now, getting back to that diagnostic test. If there's a diagnostic test performed by a physician and the results have rendered a diagnosis, let's say we had that arthroscopy, and let's say that the arthroscopy says that we have some internal derangement. That's going to be the diagnosis. Then that is going to supersede that pain code or that sign and symptom. We have a diagnosis. And so the guideline says if a diagnostic test performed by a physician and the results have rendered a diagnosis, internal derangement, code the confirmed diagnosis as the first listed diagnosis, okay? Do not code those related signs and symptoms. No, we don't code them. And why, coders? If you said because the related signs and symptoms are integral to the diagnosis, outstanding. We're getting down to the wire. Guideline L, patients receiving therapeutic services only. What does therapeutic services mean? Well, it means that they're receiving treatment. So therapeutic means treatment. So whenever a patient's receiving therapeutic services only, you're going to code as first listed the chief reason for the encounter. And you're going to code additionally all coexisting diagnoses. Now, the only exclusion to this rule is if the encounter is for chemo or radiation therapy. Chemo and radiation therapy have their own encounter codes, so you will not need to code the patient's diagnosis of cancer. You'll code the encounter code. Patients receiving preoperative evaluations only, you're going to code as first listed a code from Z01.81 subcategory, and then you're going to sequence the reason for the surgery. Next. Guideline N. ambulatory surgery. When you have a setting where you have two diagnoses, you have a preoperative diagnosis and a postoperative diagnosis, you're going to sequence the postoperative diagnosis first. Guideline O. Anytime you have routine outpatient prenatal visits, you're going to go see Section 1C guidelines. That's specific coding guideline, Chapter 15 for pregnancy conditions and prenatal conditions. Guideline P, encounters for general medical examinations with abnormal findings. Anytime a patient goes for a routine medical visit, a routine like an annual, and they find something during that encounter, Z00.00 or Z00.12 should be your first listed code. And finally, encounters for routine health screenings. You're going to find those guidelines in Section 1, C21, Chapter 21. We haven't gotten to those Section 1C guidelines, but we'll get there. Now that we've discussed the circumstance and how to code these Section 4 guidelines, I know what you're thinking. You're like, how the heck do we remember all of that? Well, I have something for you, coders. Not that you're going to remember it, but I have a little tool to help you use. Well, a tool for you to use that will help you ultimately remember the guidelines. All right, here it is. I love this tool. This is our selection of first listed code chart. I know it doesn't have a cute name, but I love it because on this chart, you've got 10 circumstances, 10 columns, okay? And in each column, you have a circumstance, all right? Column 1, signs and symptoms. Column 2, outpatient surgery. 3, observation. 4, chronic. 5, coexisting. 6, diagnostic procedures. 7, therapeutic services. 8, preoperative evaluations. 9, ambulatory surgery. And 10, general medical exam with abnormal findings. They look familiar, right? Well, they should, because these are the most common diagnoses or circumstance in Section 4. In other words, if you have a sign and symptom, then you go to the sign and symptom column, and below it, it tells you what to do. So if you have a sign and symptom, it tells you you can first list it when no diagnosis is present, or don't code it when you do have a diagnosis. Outpatient surgery, code the chief reason for the surgery is first listed. If you have observation stay, if the patient was admitted to observation for a medical reason, code the medical reason first. If the patient was admitted to observation for a complication, sequence the reason for the surgery first. If you have chronic conditions, it tells you can report them as many times as the patient is receiving treatment for them. Coexisting conditions, code them. Always code coexisting conditions if they exist or if they could affect the patient's treatment. And do not code resolved conditions, and use your history codes for past diagnoses that are pertinent to the encounter. When you have diagnostic procedures, if you have a routine lab, go ahead and use Z01.89 if you don't have a diagnosis. If a diagnostic test is performed by the physician and the results have rendered a diagnosis, this guideline tells you code that diagnosis in lieu of the signs and symptoms. And don't code those signs and symptoms because they are integral. Therapeutic services, you're going to code as first listed the chief reason for the encounter, and code additionally all coexisting diagnoses. And the only exception for therapeutic services will be encounters for radiation and chemotherapy. Preoperative evaluations, you're going to code first a code from the Z01.81 category. A preoperative evaluation is a preoperative test, or not test, preoperative exam. And then after this Z01.81, you're going to sequence next the reason for the surgery. 9, ambulatory surgery. When you have a preoperative and a postoperative diagnosis, always code the postoperative diagnosis. And 10, a general medical exam with abnormal findings, Z00.00 or Z00.12. And you might just say, Mrs. J, we just did that. Why did you do it again? I bet you learned something. I don't care if I can get you to learn something by repeating, I'm going to do it. And that's the way you learn these guidelines and are able to recognize and apply it. But the best way to learn these guidelines is through exercise. So I think you're ready for some exercises. Your guideline strength will definitely increase with practice. So let's get started. Now, the first thing that we need to do before we begin, we need to review general coding guidelines on signs and symptoms. So guideline 4, maybe 5 and 6, but really 4. I want you to know what a sign and symptom is. So a symptom is according to the patient, like a headache, and a sign is what the doctor can confirm. Now, we'll need to know signs and symptoms that are integral or related to a disease, and these signs and symptoms are often clinical indicators of a disease. So other words, it means they're related and often indicators that suggest that a patient has a disease. So let's do an exercise on identifying signs and symptoms. Then we'll do a clinical indicator exercise. All right, let's get started. All right, coders, it's up to you. It's now your turn to tell me if it's a sign or a symptom. I'm going to point to the sign or symptom in the middle of the screen, and you tell me if it's a sign or symptom. All right, let's begin. Oh, by the way, let me remind you, a sign is according to the doctor. Okay, let me put my little pointer. And a symptom, that's according to the patient. All right? Okay. Cough. Is it a sign or a symptom? All right, if you said it is a sign, outstanding. Remember, when it's according to the doctor, it means the doctor can tell. The doctor can see it. Act like a sign, like a stop sign. Sign means that the doctor can see it. Okay, well, that's probably a bad example, but it's a sign. Let's say a neon sign. Thank you, Ms. Rochelle. Yeah, she put this little neon sign. Yeah, that means that everybody can see it, not just the doctor. All right, next up, nausea. Is it a sign or a symptom? If you said it's a symptom, outstanding. The doctor can't tell if you have nausea. The doctor can assume it's nausea, but you know for sure it's a symptom. Next, vomiting. Is it a sign or a symptom? If you said it's a sign, outstanding. Yes, everyone can tell when you're vomiting, especially the doctor. Next up, lightheadedness. Is it a sign or a symptom? If you said it's a symptom, outstanding. The doctor can assume you're lightheaded, but only you know for sure. The doctor can't really tell. It's a symptom. Next, what about joint pain? Is it a sign or a symptom? Is it apparent to the doctor or is it just apparent to the patient? If you said joint pain is a symptom, outstanding. And finally, the patient has a distended abdomen, meaning that abdomen is sticking right out. Boom. If you said it's a sign, yes, that's a neon sign. Outstanding. All right, so hopefully you get it. You understand what a sign and a symptom is. Now, we got another exercise. We're going to talk about clinical indicators. These signs and symptoms are often indicators of a disease. If a patient has cough and vomiting and nausea, maybe they have the flu. Okay? All right. So, let's get started. All right, so here's my clinical indicator exercise. I know it's bootleg compared to Ms. Rochelle, but this is the best I can do. All right, so on the left, you have diagnoses. On the right, you've got your signs and symptoms, and these signs and symptoms are often called clinical indicators. So they're indicators of a diagnosis or disease. All right, so let's anxiety. Anxiety. Can you tell me what are the signs and symptoms or clinical indicators for anxiety? Is it joint pain, stiffness, or bone spurs? Is it nervousness, rapid breathing, increased heart rate, sweating? It is. So we're going to, and if you look at the others really quick, you'll see that these are the clinical indicators for anxiety. Next, allergic rhinitis. Allergic rhinitis. Well, allergic rhinitis means allergic nose inflammation. Rhinitis means nose, itis, inflammation. So if you say, look up here, is this joint pain, stiffness, bone spurs? Or is it sneezing, running nose, itchy eyes? Is it chest pain, weakness, shortness of breath? Is it fatigue, weight gain, or constipation? Which are the clinical indicators for allergic rhinitis? If you said sneezing, runny nose, itchy eyes, outstanding. Hypothyroidism. Hypothyroidism is the diagnosis. Can you tell me what are the clinical indicators for hypothyroidism? Is it joint pain, joint stiffness, bone spurs? Is it chest pain, weakness, or shortness of breath? Or is it fatigue, weight gain, and constipation? If you said fatigue, weight gain, and constipation, outstanding. All right, you're doing good, coders. You are indeed. What about osteoarthritis? What are the clinical indicators for osteoarthritis? Is it joint pain, stiffness, or bone spurs? Or is it chest pain, weakness, shortness of breath? If you said joint pain, stiffness, and bone spurs, outstanding. And finally, coronary artery disease. All right, coronary artery disease, the only one that we have left are chest pain, weakness, and shortness of breath. All right, coders, if you learned something, that is outstanding. And if you didn't learn anything, if you just learn that signs and symptoms are synonymous with clinical indicators, they are indicators of possibly a diagnosis or disease. All right, so now that we've gotten that out of the way, we've learned about Section 4 guidelines, we've learned about the definition of signs and symptoms, we've learned about clinical indicators. You know what, coders? You are ready. We are going to continue our exercises, and we are going to learn how to select the first listed diagnosis in a scenario. Before we get to those scenarios, let's go ahead and review the steps to identifying the first listed code. Number one, in your scenario, you need to inventory all possible diagnoses, signs, and symptoms, everything. Any diagnosis, sign, or symptom, write it down. Number two, identify your first listed code based upon the guidelines that we've just reviewed. And three, apply all guidelines, not just Section 4 guidelines, but all other guidelines. All right, are you ready for your first one? And of course, I'm going to walk you through this. Exercise 1. A 6-year-old patient and mother arrives at the doctor's office with complaints of congestion, fever, and ear pain. The physician examines the patient and determines that the patient has otitis media. Identify the first listed diagnosis and all other codable diagnoses. All right, so let's review our steps. Step 1. We have to inventory. Step 2. Identify the first listed diagnosis. And step 3. Apply all other guidelines. But before we get to inventorying, well, I think I do. I'm going to highlight my keywords, and then I'm going to just show you something. All right, so the patient has congestion, fever, ear pain, and was diagnosed with otitis media. So as a coder, you're going to say, oh, okay, I can do this. But what if you don't know what otitis media is? Well, this is a great time as you're studying to learn what they are. And don't feel like there's so many diagnoses that you just won't learn them. You know what, coders? By the end of this instruction, you would have seen so many that at the testing level, they are going to review the most common diagnoses, the most common ones. So you probably will have seen everything that you're going to see on this exam. So let's get started. Let's learn what otitis media is. So if you look it up, and this is the only thing that I want you to Google, if you come across a diagnosis that you're not familiar with, a simple Google search will help you. So otitis media is also referred to as a middle ear infection. Yes, so that's what it is. It's a middle ear infection, and the clinical indicators or signs and symptoms that point to the disease called otitis media are right here. It'll say, all right, well, also up here too. The patient could come in and say they have drainage or fluid from the ear or hearing loss. That's extreme. But typically, people can experience pain in the ear pain, fever, loss of appetite, vertigo, inflammation or ringing in the ears. If it's an infant, the infant could be crying. The patient could have a headache, nasal congestion, or nausea. So you don't necessarily have to have all these indicators, just one or two to be an indicator of a potential disease or disease process. So these are the clinical indicators of otitis media. Now let's get to identifying our first listed diagnosis code. All right, so here's our scenario. Now we need to do the first step, which is inventory those diagnoses, signs, and symptoms. We have congestion, fever, ear pain, and otitis media. The next thing that we need to do is identify the first listed code. All right, so how are we going to do it? This is how we're going to do it. See this purple box? It used to be white. This is our our first listed diagnosis box. This is, or table, this is Miss and Mrs. No, this is AMCI's first listed diagnosis chart, and they're here. And so let's work this chart. You go down the columns and you select all that apply. And in this case, signs and symptoms apply. Congestion, fever, ear pain, and are all clinical indicators of otitis media. So when they are, you are told do not code your signs and symptoms that are integral or clinically related to a diagnosis. And congestion, fever, ear pain are all clinically related to otitis media. Therefore, otitis media is our first listed diagnosis. How do you feel about that, coders? All right, so I do have a key point. Otitis media is our first listed and our only diagnosis. Are you ready for some more? Okay, let's go, coders. All right, so we have a 45-year-old doctoral student who arrives at the ED with complaints of fatigue, constipation, and weight gain. After administering blood work and examination, the patient was diagnosed with hypothyroidism. Now, coders, your task, you have to identify the first listed diagnosis and all other codable diagnoses. I want to remind you of your steps on the right, and I'm going to give you a few moments to identify your first listed diagnosis. And if you need to pause the presentation, feel free. Okay, let's move on. Before we solve it, let's go ahead and let's look at me identifying our inventory. We have fatigue, constipation, weight gain, and hypothyroidism. So if you don't know what hypothyroidism, it is a condition of the thyroid gland that doesn't produce enough thyroid hormone, and the hypothyroidism is also referred to as underactive thyroid. Now let's take a look at these symptoms or clinical indicators. All right, so the patient could have fatigue, cold sensitivity, constipation, dry skin, and unexplained weight gain. Now, these are the most common symptoms, but people could have lethargy, delayed puberty or slow growth, hair loss or dryness, brittle nails, enlarged thyroid or goiter, high cholesterol, irritability, sexual dysfunction, slow heart rate, sluggishness, irregular uterine bleeding. So there are lots of symptoms and signs. And you know what, coders? Let's get back on track. Let's go ahead and identify the first listed diagnosis. And again, you see these little yellow boxes that remind you we do not code clinical indicators or signs and symptoms that are integral to a diagnosis. So, with that said, let's do our 3 steps. First, we're going to inventory all diagnoses, signs, and symptoms. We have fatigue, constipation, weight gain, and hypothyroidism. Then we're going to turn our attention over to our chart, and we're going to look to see 1 through 10 to see all that apply, and 1 definitely applies. Signs and symptoms. We know we do not code signs and symptoms that are integral or clinically related to our diagnosis, which is our chief reason for the encounter. hypothyroidism, and it is our first listed code. All right, coders, so we've been at this for a while, and you know what? Studies show that when you get up and move around, you have better outcomes. So if you don't do it for you, I'm going to do it for me because I can't keep talking like this unless I have, the energy. So I'm going to get up and I'm going to move around, and I hope you do it too.
This is ISM. I heard your love is no way you're missing. You seem a little lost with your theory. There's no way you'll get it wrong. But I see it probably doesn't matter to you, but to me, have the truth on the platter. Clear stay to see you'll find the difference of different
Woo! How do you feel? I know I feel reinvigorated and I'm ready to move on. I hope you are too, coders. Exercise number 3. A 25-year-old patient arrives at the ED with complaints of ankle pain, swelling after falling and injuring her ankle. The physician sent her for x-rays. While in the x-ray suite, the patient was asked the first day of her last menstrual period. Since she did not know, a pregnancy test was administered. The results from the pregnancy test came back positive, and the x-rays revealed a fracture. The physician diagnosed the patient with pregnancy and right ankle fracture, applied a cast, and referred the patient to her OB for further management. Identify the first listed diagnosis and all other codable diagnoses or diagnoses. All right, now this might be a little more than the others, but you're going to have some aha moments. I know it. And let's go ahead and identify our keywords. So some of you might be like, oh, that's a huge scenario. It might be larger than the others, but our task is to highlight our keywords, and our keywords are our diagnoses, signs, and symptoms. That's it. So we have ankle pain, ankle swelling, pregnancy, and right ankle fracture. Coders, that is straightforward, right? Okay, now let's do our due diligence. Let's inventory. That just means write them down. So we have ankle pain, ankle swelling, pregnancy, right ankle fracture. We're going to get our chief reason for the encounter table. I know it doesn't have a name. Okay, AMCI first listed table. That is the name of it. All right, and what we're going to do is we're going to look 1 through 10 and see what applies. So if we stop at 1, signs and symptoms, you almost, to me, it seems like you almost, well, you stop at 1 most often. Doesn't always apply, but often it does. So if you have signs and symptoms, you do not code signs and symptoms that are related. And we have ankle pain. Ankle pain is related to what? Pregnancy or fractured ankle? Well, it's the fractured ankle. The ankle swelling is also related to the fractured ankle. So we're going to get rid of these two integral diagnoses. And next, we are going to determine if we should code for pregnancy and fractured ankle. And the diagnosis, well, number 5 says that when you have coexisting conditions, code all documented conditions that coexist at the time of the visit. These two coexist, so we code them. Now we have one problem. Of these two, which one is the chief reason for the encounter? All right, so some might say pregnancy, some might say fractured ankle. This is going to be your teachable moment, coders. So if you're doing other stuff like watching TV, talking to the kids, rocking the babies, stop. Here is a moment that you really need to listen to. Why? You need to answer this. You've got 2 diagnoses, and you need to answer, why did the patient go to the OR or the ED? If you can't tell, you look at what that physician did. What did that physician treat the most? Okay? What did the physician treat the most? And if you said fractured ankle, outstanding. But our case is we do know why the patient went. The patient went because they had ankle pain and swelling, and that's related to the ankle fracture. So we knew that. There was no really dispute. Now remember, fractured ankle is the chief reason for the encounter. However, you're going to code both. And that's the way it's done. And you're going to see some more scenarios where it's not as cut and dry, but this is a good teachable moment. Why did the patient go in the first place? If you can't answer that question, then you go up to your chart and you look for a reason or look for something that will help you answer your question. We have some more. Are you ready to roll? Let's go. Exercise number 4. A 14-year-old was skateboarding, listening to music, and video recording his journey along a sidewalk. He failed to see the metal trash cans along his path and ultimately collided with the cans. The boy was unconscious and taken to the ED via ambulance. Upon examination in the ED, the physician noted a Glasgow coma scale of 2, meaning that the patient was able to open their eyes due to pain and moaning. And the patient also had a finger laceration. The patient was intubated and placed on a heart monitor, and the laceration was repaired. The patient's full consciousness was restored within a few hours. Final diagnoses: scale 2 coma and intermediate finger laceration. Identify the first listed diagnosis and all other codable diagnoses. All right, coders. You've got some work to do. What are your key words? If you said scale 2 coma and intermediate finger lacerations, outstanding. See all those words, and we just have 2 diagnoses. Yeah, so don't let these long scenarios intimidate you. As you can see, they can be broken down into tiny nuggets. All right, let's go ahead and determine what is the first listed diagnosis. All right, so now our first step, we have to inventory. Yeah, we have 2. We have a level 2 coma and a finger laceration. We need to find out which of these 2 diagnoses will be sequenced first. So we're going to use our AMCI first listed diagnosis chart, And we're going to determine of the two which one is the chief reason for the encounter. All right, so when you can't really tell, the patient came in, the patient had a finger laceration and a level 2 coma, you really can't tell because they came in with the same thing. So the coding tip, and this is important, so pay attention, coders, you have to answer the question, which of the two diagnoses was chiefly treated? Which one was chiefly treated? Or which one was chiefly significant? Which one was the most significant? On site, we can kind of draw our own conclusion, but let's look at the documentation to tell the story. Well, we can assume that the level 2 coma is chiefly more significant or chiefly treated, but let's look at our documentation. The patient was intubated and placed on a heart monitor. That is significant, much more significant than repairing a laceration. In other words, stitches or sutures, much more significant. Heart monitor requires people monitoring the patient's heart. Intubation, that's a procedure. Yeah, so the level 2 was chiefly treated and or chiefly more significant or more complex than the finger laceration. All right, so that was a teachable moment. When you don't know, what is chiefly treated or chiefly significant? Now, I want to just remind you about the steps to selecting a first listed code. We tend to just do step 1 and 2, and 3 we really haven't had any examples. So this next scenario will demonstrate number 3. Are you ready? Okay, so don't forget, step 1, you do your inventory. Step 2, identify your diagnosis, your first listed diagnosis, and use that AMCI first listed diagnosis chart. And in 3, apply all guidelines. All right, here we go. A 16-year-old arrives at the ED with a head laceration and in an unconscious state. Upon admission, the Glasgow Coma Scale revealed level 2 coma. Patient was intubated and placed on heart monitor, and the intermediate head laceration was repaired at bedside. After 4 hours, the patient's consciousness was restored. The physician's final diagnoses, level 2 coma with cerebral contusion and laceration. Now, coders, identify the first listed diagnosis and all other codable diagnoses. All right, so let's go ahead and let's highlight our key terms. We have the Glasgow Coma Scale. We have an intermediate head laceration, level 2 coma, cerebral contusion, and laceration. All right, so these are our key terms. Let's go ahead and inventory. All right, so we're going to inventory level 2 coma, cerebral contusion, and cerebral laceration. And this almost seems like the other scenario, right? We have to determine, it says, which of the diagnoses was chiefly treated or chiefly significant, right? And so let's just take a guess, and we might say level 2 coma. Well, the level 2 coma was treated. They intubated this patient. They repaired the that laceration was repaired too. You know what, coders? We can say level 2 coma was chiefly the reason, but step 3 says read all guidelines. So in the real scheme of things, we would be looking up these codes. And remember, there are guidelines at the code level. So let's go ahead and let's look up these codes. All right, let's go ahead. We put our inventoried diagnosis and we're looking up our first code. We're going to look up level 2 coma. No, we're not going to look it up in the index first. Let's just assume I did, and it took me to subcategory R for 0.2 coma. But look at these red instructional notes. It says code first any associated fracture skull or intracranial injury, and it's listing your category S06. So I believe we do have an intracranial injury, and if we have an intracranial injury, it means that that level 2 coma goes from our first listed to our subsequent listed or our secondary listed. Whenever you see this instructional note that says code first, that means that that code is a manifestation code. Yes, so if something has to be sequenced before it, it's a manifestation code, but it's not in general a manifestation code. It's only a manifestation code when you have a fracture of the skull or an intracranial injury. And I believe, coders, that we have an intracranial injury because if I look up cerebral contusion and laceration, it takes us to subcategory S06.33, contusion and laceration of the cerebrum, unspecified. But if we go down to our code S06, and be mindful, it is of the same category, S06, S06. They share the same BOS. 333, contusion and laceration of cerebrum, unspecified, with loss of consciousness of 1 hour to 5 hours and 59 minutes. Well, in our documentation, this patient lost consciousness around 4 hours. All right, so the patient was unconscious for 4 hours. So this is our code, S06.333. But if we go back to our coma codes, it tells you that you're going to sequence this category or subcategory R40.2 after your contusion and laceration code. So we are going to, just so you know, we are going to sequence our coma scale codes, coma scale level 2 from subcategory R40.21 and our subcategory R42.22, we're going to code R40.222. All right. And just so you know, when you get to specific coding guidelines, chapter 18, you will review these coma scales. But just so you know, the first subcategory R40.21, this is where they measure your eyes, if your eyes are opening or not. And R40.22, this is measuring your verbal response. But since the doctor said it was level 2, then we're going to apply both. Okay. S06.333A will be our first listed code, followed by our R40.212, R40.222. These are the manifestations of our first listed code. And that A, well, coders, that's our seventh character extender, and we reviewed that not too long ago, and we didn't have room to look at this indicator, but trust me, I went to the BOS. If you want to do it yourself, go to S06, you'll see the indicators. All right, coders, I think I also want to show you something else. Well, we had some guideline teachable moments, meaning we had to apply some guideline knowledge. And the first was code first. When you see code first in the red instructional notes, that is a manifestation code. The instruction is the manifestation code. It's not always a manifestation, but read the instruction, okay? And when it says do not sequence, when it is a manifestation code, you do not sequence manifestation codes first, okay? So when you see code first language and use additional code, that is telling you the sequencing order, and anything that should be sequenced after the first code is a manifestation. And this is guideline A, section 1A13. Now the next guideline that we had a teachable moment with is section B9. Yeah, we had a combination code. The head laceration and the cerebral hemorrhage, that was one code. And the guidelines tell you that when you have a combination code, don't code them separately. So the combination code was a guideline teachable moment, and the level 2 coma, that's a manifestation. So the combination code will be our first listed diagnosis. All right, coders, I hope you had an aha moment, because we are moving along. And now, exercise 6. A 25-year-old patient arrives at the same day surgery center for the Cartiva great toe implant surgery. The patient complains of pain in the great toe and unable to wear high-heeled shoes. The patient has a history of diabetes type 2. The physician diagnosed the patient with hallux rigidus, and it is your job, coders, to identify the first listed diagnosis and all other codable diagnoses. Now, coders, you might say, well, wait a minute. If the doctor said the patient has hallux rigidus, why wouldn't that be the diagnosis? Well, it could be, but it's your job as the coder to look through the documentation to see if there's any other codable diagnosis, and if anything was chiefly more the reason for the encounter. So we have to determine what is the chief reason for the encounter, and if that doesn't work, then we go through our table and we figure out the chief reason for the encounter. Now, let's review our keywords: pain in great toe, type 2 diabetes, hallux rigidus. Okay. Now let's take a look at these diagnoses, and you know what? I don't expect you to know what these are. So let's take a look. What is hallux rigidus? Well, we've got two images. The one on the left is called hallux valgus, and the one on the right is hallux rigidus. So hallux valgus is a bunion and hallux rigidus is arthritis. That's the difference between the two. Now, the clinical indicators of a hallux bunion, well, it's actually, you can see some of those signs and symptoms. The symptoms are pain. The sign is pressure or sensitive prominence at the fifth metatarsal. So it's sensitive there because you can tell it's red, and it's prominent, it's sticking out. And great toe deviation is a sign. The great toe is going in the opposite direction. Well, we don't necessarily have to say opposite, but it's going to the left on the left foot, and if the bunion was on the right foot, it could go very right. All right, so hallux rigidus, the clinical indicators are pain, stiffness, loss of motion, and the patient can't stand on their toes. It is arthritis. In this area where you see these osteophytes, it's painful. All right, so I think we need to get back to our scenario, we're going to leave the bunion alone and we're going to take the little furry toes with us. Okay, now we're going to inventory our diagnoses: pain in great toe, diabetes type 2, hallux rigidus. We're going to get our chart and we're going to determine the chief reason for the encounter. And let's start. Let's look down our chart. We're going to start at 1 because we have some signs and symptoms. That pain in the great toe is a symptom, and we do not code signs or symptoms that are integral or clinically related to a diagnosis. And the pain in the great toe is related to the hallux rigidus. And remember, that's arthritis, right? So we're going to get rid of pain. You got to go. It's a distraction. Now we have two diagnoses. We have diabetes type 2 and hallux rigidus. All right. So the guideline that we're going to follow is, can you take a guess, coders? If you said we're going to follow guideline 2, outstanding. Yes, other guidelines apply, but guideline 2 is the most relevant. This is the guideline for outpatient surgery. It says code the chief reason for the surgery as the first listed code. So the chief reason for the surgery, is it diabetes? No. Is it hallux rigidus? Outstanding, yes. And remember, the patient had same-day surgery. When you have same-day surgery, follow the outpatient surgery rules, if applicable. Now, you might say, well, hey, there are other guidelines that apply. You have coexisting conditions, you have chronic diseases. Absolutely, but always follow the most relevant guideline. And the most relevant guideline is that the patient was at the same day surgery. You'll often find that you're going to use these chronic diseases and this coexisting condition, and it would still lead you to the same answer. But always remember, try when you can to follow the most relevant guideline. And our answer for exercise 6, hallux rigidus. Now you might say, Mrs. J, some of these are just so obvious you can just easily tell. You can, but once you get more advanced, and you're going to move on very soon, you're going to see this chart is going to help you because it's not going to be so cut and dry. It keeps your brain focused on what you need to be looking at, what you need to do to determine the first listed code. But I didn't want to go too difficult. That wouldn't be right. Okay, so we've got our last exercise, and you all are doing fantastic. I just know it. Exercise 7. And because this is the last one, I want to reiterate the steps. Step 1, you're going to have to inventory all possible diagnoses, include your signs and symptoms. Number 2, identify your first listed diagnosis. And 3, apply all guidelines. Patient arrives to the physician's office with complaints of severe abdominal pain. She has a history of hypertension, diabetes mellitus, and gastroesophageal gastroesophageal reflux disease. I apologize. The patient was sent for upper GI studies, and it was determined that the patient had a ruptured appendix. Code the first listed diagnosis and all other codable diagnoses. Okay, coders, what are your keywords? Your keywords are going to be what you're going to inventory. You're going to inventory your abdominal pain, hypertension, diabetes mellitus, gastroesophageal reflux disease. I kind of use disease and disorder, so that kind of stumped me for a minute, but we're going to say disease, and ruptured appendix. All right, let's do what we need to do to find the first listed code. Step 1, we're going to inventory everything. You all with me? Step 2, we're going to locate or identify our first listed code. We're going to do it using the AMCI first listed code chart, and we're going to stop at signs and symptoms. Do we have any signs and symptoms that are integral to a diagnosis? Well, let's just reveal what the diagnoses are. HTN, diabetes mellitus, GERD, and ruptured appendix. And we do have severe abdominal pain. We know that's a sign. No, it's not a sign. It's a symptom, right? So if abdominal pain is a symptom, it could be related to either the GERD or ruptured appendix. So guess what? It gotta go. You gotta go. Bye. Okay. Now we've got 4 diagnoses here. Our job is to determine the chief reason for the encounter. Number 5 says that when you have coexisting conditions, you code all documented coexisting conditions that exist at the time of the encounter. They all exist, and or if they impact the patient's treatment. So they do exist, and they could definitely impact the patient's treatment. So we are going to code all of them, but our task is to determine which one of the 4 is the chief reason for the encounter. Now, if you were paying attention, you would know that the patient was sent. Well, the patient arrived with abdominal pain. The patient was sent for upper GI studies, and it was determined that the patient had a ruptured appendix. So ruptured appendix is our first listed code. It was the most chiefly treated and chiefly significant of the 5 during this encounter. So it is our first listed code, and you would code all other secondary or subsequently. All right, that's it. How do you feel, coders? How do you feel? Well, if you want some exercises to do on your own, if you are in the AMCI course, just go into your LMS. You have a handout and you can practice. Now let's go ahead and let's end things by summarizing. Remember, we were studying today Section 4 guidelines. These guidelines only pertain to outpatient encounters, outpatient facility, and doctor visits, okay? And we do not code. This is really significant. So this is a guideline you probably need to keep in your head. You don't code inconclusive diagnoses. Don't code them. You have to code to the highest level of doctor's certainty. If the doctor's not certain, don't code it. Another thing, code to the highest level of specificity. And always, always, first, code the chief reason for the encounter. Now, if you don't know what that is, use the chart and you are good. Here's the chart. And it's in your MCG manual. It's not purple, but it is white and you should use it. So again, your chief RFE, reason for the encounter, and code to the highest level of certainty and specificity. Congratulations, coders. You have finished Part 3. You've learned Section 4 guidelines. You've learned how to select the first listed code and how to identify all other codable diagnoses. Outstanding. And in addition to completing Section 4 guidelines in Part 4, you have completed the entire 4-part series on AMCI Introduction to ICD-10-CM Coding. So you should know the history of ICD-10-CM. You should be familiar with ICD-10-CM conventions and general coding guidelines, how to identify ICD-10-CM codes using mnemonic terms, and finally, what you've learned in this lecture, the Section 4 guidelines and first listed code selection. So what does this all mean? Well, it means you're ready. Yes, you're ready for CPT coding instruction. Now, these are the procedures. ICD-10-CM are the diagnoses. Now, it's time to turn our attention to the procedures. And if you intend to be a professional coder, that means you're coding for professionals. This is this is your book. This is where you need to do most of your work. Okay, so go ahead and get started. You are ready. And this completes the presentation. I'm Mrs. J for AMCI. Until next time.
4,000 exam passers and free classes at AMCI. Learn to code straight from home or on the road at AMCI. We're on the East Coast, the West Coast. We're all around the world. AMCI, AMCI.